Welcome to today's nephrology grand rounds. We are really delighted to have Dr. Aisha Shaikh from UPenn present to us on kidney toxicities of cancer therapies. Dr. Shaikh is an associate professor of nephrology. She's the director of Onco-Nephrology at UPenn in Philadelphia. She did med school in Pakistan and then nephrology training at the Mayo Clinic. And before coming to UPenn, she was the onco-nephrologist at the Memorial Sloan Kettering Cancer Center in New York. Prior to that, she has had several leadership roles, including being the renal service chief at the James Peters Center in Bronx, New York. Welcome, Dr. Sheikh.
Thank you so much. And thank you, Swap, for the invitation. And thank you for everyone for being so early for today's talk. So, the title is Kidney Toxicities of Targeted Cancer Therapies. And my goal in the next 40 to 45 minutes is to give you an overview of targeted cancer therapies and then really dive into the nephrotoxicity and electrolyte disorders with these targeted therapies. And what I would do is also share some of the clinical cases that I've seen over the past few years. So it kind of hones in the point that I'm trying to make about certain therapies. I'm hoping to have 10 minutes or 15 minutes in the end for questions. So if you can save the questions for the end, that would be fantastic. So I'm sure this group is well aware that cancer is the leading cause of mortality worldwide. And if you look at the Global Cancer Observatory data, there were about 20 million new cancer cases in the year 2022, with approximately 10 million cancer-related deaths globally. We also recognize that the incidence of cancer and cancer-related mortality is expected to rise simply because of risk factors for cancer, such as obesity, environmental risk factors, and an aging population, of course. So there is overall a need for efficacious and non-toxic cancer therapies. And so conventionally, we all grew up with cancer therapies, which included cytotoxic chemotherapy, radiotherapy, and surgery. And just to give you an idea, when you give someone cytotoxic chemotherapy, you are not just killing the malignant cells that are rapidly dividing. Unfortunately, those therapies will also affect normal cells. On the other hand, the targeted cancer therapies, and I put quote unquote targeted because it's not a very accurate term, but generally speaking, targeted cancer therapies are meant to attack a biologically important process that is central to the pathogenesis of cancer. Now, if you look at the concept of targeted therapies, that goes back all the way to the 1890s, and Paul Ehrlich, who was a Nobel Prize winning German scientist, envisioned this concept that if you have a therapy that targets a specific organism and doesn't hurt the normal tissue, that would be the ideal sort of form of therapy. Hence, it was called targeted therapy. And at the time, the term magic bullet was given to that concept, and it was initially applied to infectious diseases. But if you look over time, this concept has expanded to cancer therapeutics, and it's really most prominently seen in drugs that are antibody drug conjugates, where you have antigen recognition potential in a molecule that you're administering to the patient that identifies the antigen on cancer cells and literally delivers the or rather the targeted therapy or cytotoxic therapy directly to the cancer cell. And this is what we see in drugs like mirvetuximab and enfortumab that are now being used for so many GU cancers that we see in our clinics. So in general, targeted cancer therapies either block enzymatic pathways that are involved, unique to a certain cancer, and hence block cancer growth, or they can even target abnormal proteins that are encoded by mutated genes in malignant cells. And we'll talk about some of those therapeutic agents. And then, of course, some targeted therapies will harness your own immune system to attack the cancer cells. And this includes therapies like immune checkpoint inhibitors and CAR T therapy. Now, today's talk, I'll focus mainly on targeted therapies that includes monoclonal antibodies, antibody drug conjugates, small molecule inhibitors, and briefly I'll talk about the PERT therapy, which is the peptide receptor radioligand therapy. What I won't have time to discuss today is immunotherapy, such as immune checkpoint inhibitors and CAR T therapy. But if there are questions from the audience, I'll be happy to take them at the end of the talk regarding those therapies as well. So when you look at a targeted cancer therapy or targeted drug, generally speaking, they're divided into macromolecules and small molecules. And I do want to emphasize, just because an agent is small molecule, it doesn't make it a targeted therapy. There are several cytotoxic therapies like gemcitabine, doxorubicin, that are technically low molecular weight, but that doesn't make them a targeted therapy. However, when you look at targeted therapies and you look at small molecules, they're generally things that are less than 1,000 Daltons versus macromolecules that are much larger. And the reason this distinction is important clinically is small molecules, being small, have more cell penetration, so may have more diffuse systemic side effects. And typically, because they're small molecules, they can be orally absorbed, and so they're usually administered orally. On the other hand, macromolecules are things like monoclonal antibodies, antibody drug conjugates that are typically given intravenously and tend to have less systemic side effects compared to the small molecules. So since I'm in Philadelphia, I have to mention that the Philadelphia chromosome was the first genetic abnormality linked to cancer. And this is truly a remarkable discovery that was made in the 1960s. And it was approximately 40 years later that a drug targeting this chromosome, imatinib, came into practice or was FDA approved. And literally, since then, it has changed the landscape of targeted therapies. And I'll show you the explosion of FDA approval of targeted therapies since 2001. But most people think imatinib is the first targeted therapy, but if you look at it, it was really trastuzumab, which is the anti-HER2 monoclonal antibody that was approved for HER2-positive breast cancer in 1998, is technically the first targeted therapy. And then, of course, 3 years later, it was imatinib, which targeted the BCR-ABL. And after that, you can basically see the absolute explosion of these therapies. And this slide goes up to 2021. And since then, there have been even more agents. So I will try to discuss at least most of these targeted therapies in my talk today, but there might be some that I don't mention simply because either they are not commonly associated with kidney-related side effects, or we just haven't found the association yet. So the concept of targeted therapy is this, that it just affects the cancer cells, but in reality, there are many off-target adverse effects with these therapies. And this shouldn't surprise us. And since we are talking about kidney toxicities in this talk, a lot of these pathways or enzymes that are affected by these targeted therapies are expressed in the nephron. So it is absolutely not surprising that these agents would result in nephrotoxic or electrolyte disorders. Now, a common question that comes up is how common are renal adverse events with these agents? So this is an old study, almost 10 years old, but the point of this slide is to emphasize that the renal adverse events are pretty common with these therapies. They're not always extremely severe, and you may and I may not see them in clinic because they may not even get referred to us, given the fact that they may not be extremely severe for the oncologist to do that. But if you look at the renal adverse events in the FDA adverse event reporting system, which is the FHIR system, about 3,000 patients were in this cohort, and about 47%, half of them, had some electrolyte abnormality that was attributed to these agents, or at least the patients were on these agents when they developed the electrolyte abnormalities. About 40% had kidney injury, and about 11% had hypertension. So the purpose of this slide is not so much to go into the exact incidence of these abnormalities, but to just recognize that the adverse events are commonly seen with these agents related to the kidney. So when talking about targeted therapies, I have to start off with one of the most commonly used targeted therapies. So that's the vascular endothelial growth factor signaling pathway inhibitors, or VESPs, and they include the direct acting VEGF inhibitors, such as bevacizumab, or anti-angiogenic tyrosine kinase inhibitors, such as lenvatinib, and of course, there's a long list. We all have seen these patients in clinic, and we know hypertension is extremely common with these drugs, and the onset can be within hours to days, depending on the definition of hypertension used in different studies. 20 to 90% reported adverse effect of hypertension from various studies and with these agents. Similarly, proteinuria, 20 to 60% patients tend to develop it, and onset again days to weeks with these agents. There was a recent study from the group in Boston that looked at the risk factors for VESP therapy associated grade 3 hypertension and grade 2 proteinuria. So for hypertension, they found the strongest risk factors to be older age, GU malignancy, and in their cohort, direct VEGF inhibitors such as bevacizumab had a higher or greater risk of hypertension compared to TKIs. On the other hand, proteinuria was predicted by prior history of coronary artery disease, perhaps indicating general endothelial injury or disease that pre-exists in these patients. And of course, baseline systolic blood pressure being high. And once again, TKIs were more commonly associated with proteinuria. What was truly interesting to me in this study was that the rate of discontinuation of VESP therapy. So within 60 days after onset of grade 3 hypertension, 35% in 35% cases, the therapy was discontinued. And similarly, 60 days after onset of grade 2 proteinuria, 44% patients had discontinuation of therapy. Doesn't mean that it was discontinued due to these adverse effects, but definitely an interesting association, something we've seen in our practice as well that I'll touch upon in a second. But one important point I want to make is we've all seen patients with TMA, or at least read about patients with TMA with these agents. And this finding, our pathologist always makes it a point to tell us that when they see the specific finding that on the biopsy, they're pretty certain it's due to VESP therapy. And what they describe as these glomerular capillary microaneurysms filled with this pale, shiny, hyaline-like material. What they don't see typically are platelet and fibrin thrombi. So this could be a really good clue for you if you have a patient on multiple agents and all of them are associated with TMA, like VESP plus gemcitabine, VESP plus liposomal doxorubicin. And if you see this finding and you don't want to stop everything that the patient's on, you could stop and then reintroduce the alternative agent and not perhaps the VESP therapy, because this finding is more consistent with VESP-associated thrombotic microangiopathy. Now, going back to that proteinuria question that I said, which is something that we are looking at, and I'll explain to you how we are planning to study that. But if you look at the biopsy data when patients develop proteinuria and AKI with these therapies, TMA tends to be a more common finding with direct VESP inhibitors such as bevacizumab and podocytopathies like minimal change disease is more commonly seen on the biopsies in patients who are on tyrosine-kinase inhibitors. Problem is a lot of these patients are not biopsied anymore, so we don't know any recent data on this. But what's interesting is that when these patients develop proteinuria, and I'm not talking about TMA, generally when they develop TMA, you have to halt this therapy. But if they develop proteinuria alone and you stop the therapy, we tend to see resolution of proteinuria that is much quicker with TKIs versus patients who are on direct VEGF inhibitors. What the question that intrigues us is, should we be stopping this agent in patients who have asymptomatic proteinuria without AKI, without features of TMA? And the short answer is we don't know what the appropriate management is. A lot of oncologists will at least temporarily hold the therapy and then perhaps reintroduce at a lower dose or different agent within the same class of therapy. But we are planning to look at about 500 patients who develop 2 grams or more of proteinuria with these agents. And we want to see if the therapy was discontinued versus continued versus changed to a different agent. Did the kidney outcomes differ in those groups? So something to be aware of, that we stop the therapy typically, but we don't know what the appropriate management for asymptomatic VESP-associated proteinuria is, and that remains to be seen. So now I'm going to talk about BCR-ABL inhibitors. And as you know, this is a tyrosine kinase that is the activated protein gene product of the Philadelphia chromosome seen in CML. And I've listed the BCR-ABL inhibitors here, and the reason I've listed the receptors they target is their side effect profile within this group can differ. So, for example, dasatinib is not just a BCR-ABL inhibitor, but it also targets the PDGFR receptor. Similarly, ponatinib is a TKI, but it also affects the VEGF receptor. So, dasatinib and ponatinib are more commonly associated with proteinuria because these receptors are expressed in the podocyte. On the other hand, imatinib is more commonly associated with AKI. So if you look at case reports and case series, there's a fairly decent association of imatinib with AKI and CKD. Of course, it can cause rhabdo and TLS and tubular injury-induced Fanconi syndrome, but you can also see a very subtle rise in creatinine in these patients, and it can be so subtle that the patient may stay on the drug for several years till the oncologist suddenly notices the GFR appear in red on the lab report. And if you look, there's a trend towards rising creatinine over a few months to years. In one large case series, AKI was seen in 7% patients and CKD in approximately 12%. And as I said, the AKI onset or CKD can be very severe or can be very subtle. And generally speaking, it can be reversed if you halt the therapy and sometimes switch to another agent. So this is a important case to keep in mind, and I'll come back to imatinib-induced AKI in a second. But I also want to emphasize that dasatinib rarely causes AKI, but it is more commonly associated with proteinuria. But AKI can occur with it. In one case series, about 60-some patients with CML, there was nephrotic range proteinuria reported in 9% patients with dasatinib. And in all of those patients, the proteinuria resolved once dasatinib was discontinued, and those patients did well when they were switched to a different BCR-ABL inhibitor. So it's not that you necessarily cannot use an agent within the same class of drug if you develop this problem. And this dasatinib related podocyte injury has been described by the group who was at Mount Sinai. And bottom line is that dasatinib alters the podocyte actin cytoskeleton. And remember, I told you the different receptors that these different BCR-ABL inhibitors are targeting. So this is a patient of mine that I saw a few years ago. She's 72 years old. She has baseline CKD, and she gets started on dasatinib for CML in January of 2021. 10 months later, she presents to my clinic with extreme fatigue, and we get labs, and she has a creatinine of 24. And we admit her to the hospital. We get a kidney biopsy. It shows acute tubular injury. We hold the dasatinib. Her creatinine improves, and we very cautiously start her on imatinib for her CML. And she has remained on the same dose for more than 4 years now. And her creatinine, as you can see in the bottom, has remained quite stable in that 1.6 to 1.9 range. So this is an example where you can switch between different agents within the same class of drugs if the patient is responding to that therapy from a cancer standpoint. So in this case, the final diagnosis was acute tubular injury due to dasatinib. And then just to focus on that green box in the bottom where AKI can occur and you could discontinue drug, reduce the dose, or switch to an alternate BCR-ABL inhibitor. And proteinuria, which is mainly seen with dasatinib and ponatinib, you may again switch to a different agents, and you may have to use corticosteroids, especially if they have very heavy proteinuria, presumably due to podocytopathy, such as minimal change disease, which has been shown in biopsy studies. So now I'll switch gears and talk about the epidermal growth factor receptor inhibitors, EGFR inhibitors. So these agents block the activity of epidermal growth factor receptor, which is a protein that's involved in cell growth, division, and survival. This is also the protein, a receptor that's expressed in the distal tubule. So you can now immediately guess what side effect it could have. So broadly speaking, this category is divided into anti-EGFR monoclonal antibodies, such as cetuximab and panitumumab. And if you look at the right side, these agents are typically used for colorectal cancer and head and neck cancer. The bottom, you see the small molecule EGFR tyrosine kinase inhibitors, and these includes agents like erlotinib, osimertinib, and these typically are used for non-small cell lung cancer patients. So anti-GFR monoclonal antibodies, the ones like cetuximab and panitumumab, are very commonly associated with hypomagnesemia. And as I told you, the EGFR receptor is expressed in the distal tubule and it crosstalks with the TRPM6 channel, which is involved in magnesium absorption. And when it inhibits that channel, you get magnesium wasting in the urine and patients develop severe hypomagnesemia. In fact, the hypomagnesemia can be extremely severe in some of these patients where they require very frequent intravenous IV magnesium infusions, sometimes once or twice a week or even more. Because of the hypomagnesemia, patients can develop hypoparathyroidism and can have hypocalcemia, and then the hypomagnesemia in itself can also lead to hypokalemia. Interestingly, if you stop these agents, the hypomag resolves pretty quickly, which is very different from agents like cisplatin and carboplatin, where hypomagnesemia can persist for some time even after you stop the therapy. AKI and proteinuria are rare, but are reported with these agents. On the other hand, the EGFR tyrosine kinase inhibitors somehow do not inhibit the EGFR receptor in the distal tubule of the kidney as effectively as the monoclonal antibodies. So the hypomagnesemia is not as severe with these small molecules. However, there are some reported cases of membranous nephropathy and minimal change disease, and also AKI with these agents. So I had a patient who was 88 years old, extremely functional, had stage 3B lung cancer with this EGFR exon 19 deletion. And he was started on osimertinib, 80 milligrams daily in July of 2024. 3 months later, his creatinine went up from 1 to 1.8. We checked a cystatin C, which was also elevated. Blood pressures were fine. His urine microscopy showed coarse granular cast, no RBCs, WBCs. And this one, it looked like real AKI. And of course, 88-year-old on Plavix, we didn't want to biopsy him right off the bat. So the oncologist decided to reduce the dose from 80 milligrams to 40 milligrams. And his creatinine improved. And actually, I don't have the data beyond January 2025, but I can tell you it's still holding pretty steady. And interestingly, the urine microscopy showed no more coarse granular cast. And so in this case, it was perhaps a dose-related effect of osimertinib, which was causing acute tubular injury. And these patients need to be monitored closely, but his response to this therapy from a tumor perspective was so good that both the patient and the oncologist were very reluctant to stop therapy completely. So we took middle ground and reduced the dose, and it worked. Now, whether the cancer therapy is still as effective or not remains to be seen. But this is one approach that can be taken in some of these EGFR inhibitor-related toxicities. So just to summarize, again, at the bottom right corner, the hypomagnesemia can be pretty severe. We've used IV MAG, amiloride, SGLT2 inhibitors, but frankly speaking, these patients typically require a lot of IV MAG. And if they develop AKI, dose reduction of the agent can be tried if the AKI is not very severe. And proteinuria has been reported, but extremely rare. And in those cases, the case report suggests discontinuation of the agent and potential use of corticosteroids if the proteinuria is very severe. So now I'll move on to the cyclin-dependent kinase 4/6, which is CDK4/6 inhibitors. And these agents block the transition from G1 to S phase of cell cycle and thereby prevent cell cycle progression and cancer growth. The three agents that you should be familiar with are palbociclib, ribociclib, and abemaciclib. And these are used for HER2-negative breast cancer patients, although they are being used in the clinical trial setting for other cancers, such as sarcomas, and I'll share a case with you in a second with that. But what is important is these agents are more commonly associated with pseudo-AKI because they inhibit the MATE1, MATE2, and OC2 transporters in the tubules that are responsible for secretion of creatinine. However, you also need to know that they have been associated with true AKI, and you really have to evaluate these patients carefully in order to not miss a true AKI. So in this case series, there were 6 patients, all had severe AKI. That's why they got biopsied. And in that series, ATI or acute tubular injury was present in 5 of them, and acute tubular interstitial nephritis in 1 of them. And what's important is they can develop these changes many, many days after they've been on this therapy. So it doesn't have to be immediate. So you have to you have to watch their creatinine, or at least the oncology team needs to watch their creatinine. So this is a patient of mine that I saw, a 73-year-old who has type 2 diabetes for more than 10 years and had HER2 negative breast cancer. And she was started on palbociclib in 2017. And then in 2023, she had a gradual rise in creatinine from 1.1 to 1.5 over a year. And then she presented to the hospital with a severe AKI of 5.5 creatinine. So a biopsy was performed, and it showed tubular injury and tubular interstitial nephritis. And so we attributed that to palbociclib, and we, of course, held the drug, and corticosteroids were initiated for the interstitial nephritis. And we tapered the steroids over 10 weeks. And you can see in the bottom panel that her creatinine did improve to 2 and remained stable, didn't return to her baseline, but still there was improvement. So the diagnosis of acute tubular interstitial nephritis due to palbociclib was made. And this is another case, a patient of mine who was in a trial who had history of liposarcoma and had a splenectomy because he had metastatic disease. And interestingly, in splenectomy patients, you have to keep a high sort of a suspicion for tick-borne diseases. And he presented to our hospital first with babesiosis and hemolysis. And when I first saw him, it was really for AKI, which we attributed to heme pigment induced tubular injury. But fortunately, as his babesiosis got treated and his hemolysis eventually resolved, his creatinine also improved and stabilized around 1.4. So now he's enrolled in a trial, and a few months after that episode of AKI, he starts abemaciclib, and his creatinine goes up from 1.4 to 1.8. And the cystatin C that we checked at the same time, and you can see there are multiple cystatin Cs there, was always lower than the serum creatinine. And his urine studies were absolutely benign, no RBCs, no WBCs, no protein. There was no evidence of any abnormal cast. And then because the patient was so nervous about this, he went to another institute and had a measured iothalamate clearance, which was reassuring, and it was stable. So in this case, the final diagnosis was pseudo-AKI due to abemaciclib. And I want to emphasize that abemaciclib, of all the 3 agents, ribociclib, palbociclib, and abemaciclib, among all these 3, abemaciclib is the most commonly one that's associated with pseudo-AKI. In fact, in the clinical trial, up to 20 to 25% patients had elevation in creatinine, which was attributed to pseudo-AKI. So this is something you have to keep in mind when these agents are being used, because you can have true AKI and simultaneously you can also have pseudo-AKI. And sometimes the distinction can be extremely difficult because there's no good marker that you can use in cancer patients that's 100% reliable. So to summarize, patients can develop acute tubular injury, pseudo-AKI, and as I showed you, acute tubular interstitial nephritis, which necessitates discontinuation of therapy and potential use of corticosteroids short term. So now I'll talk about the anaplastic lymphoma kinase inhibitors, or ALK inhibitors. And this is important because in lung cancer patients, in about 3 to 7% patients, you can see this oncogene. And what it is that the ALK gene, a portion of the ALK gene is fused with the EML4 gene. And so when patients express this oncogene, or their tumor expresses this, the oncology team will use these agents after they're done with their cytotoxic therapy to maintain them in remission, or at least to control the tumor growth. So in this category, there are lots of agents: crizotinib, lorlatinib, and then alectinib. And I'll share a clinical case with you, but it's also important to note that although they are in the same category, I've put the receptors and pathways that each of them target. And this might be responsible for a variation in side effect profile that you can see within these different agents. So for example, in this review article, I like it because it kind of highlights the variety of things you can see with these ALK inhibitors. Pseudo-AKI, of course, is potentially a finding, but acute kidney injury can also occur, and I'll show you an example of that. Edema tends to be more with crizotinib, and a very interesting, unique finding is the kidney cyst development and even kidney cyst progression that you can see with crizotinib tends to be a more drug-related effect rather than a class-related effect. But if the patient is on crizotinib, then generally speaking, their kidneys have to be imaged every few months to monitor cyst development or cyst progression. Interestingly, the cysts do regress after discontinuation of therapy. There are some very few but rare cases of photocytopathies and electrolyte disorders also that are reported with these agents. So this is a patient of mine, 69-year-old, who has type 2 diabetes and is on an SGLT2 inhibitor. And he develops stage 3 lung cancer with the ALK rearrangement. And so he finishes treatment with pemetrexate and carboplatin, and then is started on alectinib. And within a month, his creatinine starts to creep up, but then it goes higher and higher with each month. And you can see in December 2023, it's 1.1. And by the time he's referred to us in November of 2024, the creatinine is up to 2.0. A simultaneous cystatin C was also elevated. And in this case, the patient refused a kidney biopsy. So alectinib was stopped in November. And we monitored his creatinine and it improved. And the urine that had showed granular CAS before did not show that again. Of course, you saw glucoseuria in this patient, but he was on an SGLT2 inhibitor, so we didn't think that was a proximal tubular dysfunction caused by this agent. And then after the AKI had improved, he was started on brigatinib, which is also an ALK inhibitor, and was monitored very closely and tolerated that quite well. So just like the other example I showed you, this is also one of those agents where you can try to switch around within the same class of drugs because each drug may have a slightly different side effect profile and the patient may be able to tolerate it. So this is something the oncology team is good at our institute, and typically they work with us in doing so. So in this case, final diagnosis was acute tubular injury due to alectinib, but patient was able to tolerate an alternative ALK inhibitor in this case. So just to summarize, true AKI and pseudo AKI can occur with these agents. You can try to switch to a different ALK inhibitors. I don't know if there's any data on lowering the dose, but nevertheless, these agents are newer. So as we learn more, I'm sure we'll have more ideas, more case reports come out. And unique side effect, as I mentioned, is mainly with crizotinib, which affects or causes kidney cysts. So then I'm going to switch gears and talk about the Bruton tyrosine kinase or BTK inhibitors. And the main thing to remember is that ibrutinib and zanubrutinib, these agents can cause acute tubular injury, ATIN, but the main purpose I'm talking about them that is practically important for nephrologists is that these agents can also increase risk of bleeding. So if you have a patient with AKI or something else that requires a kidney biopsy, you should be aware of that adverse effect. Of course, if they have acute tubular injury, typically in these cases, you have to discontinue the drug. And the reason BTK inhibitors affect the or impact risk of bleeding is because they literally are involved in multiple pathways of platelet signaling. And so they inhibit the BTK pathway, but you can see in this slide there are many pathways that ibrutinib, for example, inhibits that is involved in platelet signaling. Now, ibrutinib is the prototype drug and typically most commonly associated with bleeding, but generally speaking, from a practical standpoint, all BTK inhibitors are held 3 to 7 days prior to biopsy. Every institute has their own protocol. At MSK, we would hold them a week before, and Penn also, we hold them a week before biopsy. So there's something practical to keep in mind if you ever see a patient who needs a kidney biopsy who's on one of these BTK inhibitors. So now I'm going to talk about some of those rarer agents, and one of them is gamma secretase inhibitors. And these GSIs are the agents that affect the Notch signaling pathway. Some of you may be aware there's a lot of research done on the Notch pathway in the kidney, CKD, etc. But interestingly, the Notch pathway dysregulation promotes epithelial mesenchymal transition and hence is involved in several malignancies of mesenchymal origin. And I'll show you some data, and this specifically impacts desmoid tumors, etc. So there's several gamma secretase inhibitors that are either one is approved and several others that are still in clinical trials. As time goes on, we may see more of these agents in clinical practice. But the one therapy, which is nirogacestat, which is a gamma secretase inhibitor, is the first therapy that was approved for desmoid tumor in 2023 based on this NEJM study that showed that it was effective in adult patients with desmoid tumor. But I've highlighted that in the adverse effects section, you can see that it caused hypophosphatemia in about 42% of the recipients of nirogacestat and not so much in the placebo group. So this is of interest to us. So our center at MSK was part of that trial. And so we looked at 17 patients, and you may say only 17 patients, but desmoid tumors are very rare. And even in that NEJM study with multi-center study, there were very few patients in the clinical trial. So this is one of those rare tumors. But we looked at 17 patients. Some of them had gotten nirogacestat, and some of them were actively enrolled in the AL101 trial, which is another gamma secretase inhibitor. And we also found that in those 17 patients, 12 had hypophosphatemia, but we found that diarrhea was one of the most common explanation for patients who had hypophosphatemia. None of the patients without hypophosphatemia had diarrhea. We didn't have urine phosphate on all of these patients, and so we can't really say if phosphaturia contributes to hypophosphatemia. And that was of interest to us because remember, I told you these agents are used for tumors of mesenchymal origin, and those are the same kind of tumors that also tend to secrete FGF23. So that we were interested in knowing if there was also phosphaturia contributing to hypophosphatemia. But unfortunately, we don't have enough patients with urine phosphate data to make that conclusion. However, we had FGF23 levels in 4 patients with hypophosphatemia, and in none of those patients, the FGF23 was elevated. So what we can say is that diarrhea seems to be the most important contributing factor to hypophosphatemia in these patients. I also want to talk about the phosphoinositide 3-kinase or PI3K inhibitors. These are very commonly used in breast cancer patients. And the reason I want to talk about it is not because of the nephrotoxicity, but because these agents cause severe insulin resistance and can cause a profound hyperglycemia. If you've seen one, you'll know one. And a lot of these people get SGLT2 inhibitors, or you may have a patient with CKD who's already on an SGLT2 inhibitors who started on this therapy. So you should be aware of this, that these agents are associated with DKA quite a bit. And if you look at the MSK data, small numbers, but people who were on alpelisib, which is a PI3K inhibitor, plus SGLT2 inhibitor, had significantly higher number of DKA incidents. Of course, small numbers, but just look at the number of patients who got this combination. 2 out of 12 developed DKA versus people who were on a non-SGLT2 inhibitor or alpelisib alone. Among 91, only 1 DKA, and among 44 patients, only 2 DKA. So based on this, at our institute, we changed the policy where we did not give SGLT2 inhibitor as a first-line therapy to people on alpelisib. And if they were on SGLT2 inhibitor for CKD, then we would take them off of it, at least before we had their blood glucose under control. So this is something as a nephrologist you should be aware of, and we would use it not as first line, but after metformin and lifestyle modifications. And we had our endocrinologist would have a very strict counseling system for these patients to not use SGLT2 inhibitors on days they were sick or fasting and consumed less than 50% of their usual caloric intake. So something as nephrologists to be aware of, that this combination is associated with high incidence of DKA. And this is an agent that you might see in your practice, and patients are on clinical trials on TDAP inhibitors. And so you have to recognize they may not have a name or a drug name, but if they're enrolled in clinical trials, it's really important to talk to your clinical trialist our oncology team, on the oncology team, to understand what these molecules are, so you can do your own research to see if they have any nephrotoxic effects, because you may get consulted for various kidney-related adverse events in these trial patients, and you may not know what VT3989 is. So bottom line is that TYAP inhibitors are agents that are being used for mesotheliomas and several metastatic solid tumors. And what happens is that the Hippo pathway is involved in YAP, which is yes-associated protein, and TAZ activation. And these are involved in uncontrolled cell proliferation. So TYAP inhibitors essentially block this pathway and is hence used for treatment of cancer. But the same yes-associated protein is also an essential component of glomerular filtration barrier that promotes podocyte survival. So not surprisingly, the TYAP inhibitors can cause proteinuria. And as I mentioned, this was identified by the group at Mount Sinai, that how the Hippo pathway is involved in YAP signaling and disruption of the actin cytoskeletal system of the podocyte. So when you see these patients, you should look out for proteinuria. And already we were getting these consults at MSK where patients were enrolled in these trials, and they were either being admitted for AKI for unrelated reason. I had a patient with obstructive uropathy, but had worsening proteinuria, which was not explained by the obstructive uropathy, and was on a TDAP inhibitor. And this was a clinic patient of mine who I saw, who within 1 month of starting a TDAP inhibitor started experiencing increase in albuminuria. So this patient is a 41-year-old with type 1 diabetes for more than 10 years, and it started on this VT3989 TDAP inhibitor for this very rare epithelioid hemangioendothelioma. And so one of the things you will have to do is, and the oncologists, the trialists do this, but they'll refer the patient to you and you have to decide what to do. So fortunately, in none of my patients, the proteinuria was severe enough for us to biopsy them or to halt therapy, but this is something you should be aware of. And then this slide is basically highlighting that I don't have time to go over every single drug that causes kidney toxicity, but I've highlighted some of the important ones that I wasn't able to discuss in detail, but these are important. And I'll briefly in the next couple of minutes talk about some important things here. So proteasome inhibitors that we use for myeloma. So carfilzomib is very commonly associated with renal TMA. But I want you to know that bortezomib, there are case reports of TMA. People think bortezomib doesn't cause TMA, and we've had biopsy-proven cases of that. So just be aware of it. But bortezomib is also known to cause this interstitial nephritis, and sometimes it can have that granulomatous interstitial nephritis pattern of injury. We all are aware of mTOR inhibitors from our experience with sirolimus in the transplant world, and everolimus and temsirolimus are agents that you'll see your oncology team use for, especially for renal cell carcinoma patients. So of course, proteinuria is something you should be aware of. The fibroblast growth factor receptor inhibitors are used for urothelial cancer. So the way to remember it is it does exactly the opposite of what FGF23 does. So these patients can have hyperphosphatemia and theoretically can cause calciphylaxis, although I haven't seen any published reports of calciphylaxis. The BCL2 inhibitors, such as venetoclax, which are used for leukemias, as you know, can cause TLS and acute tubular injury. And they figured out a good way to avoid this in most cases by gradual increase in dosing of venetoclax, which tends to lower the TLS and tubular injury incidence. I've combined BRAF and MET inhibitors because BRAF inhibitors are the main ones that are associated with tubular injury, but BRAF and MET are typically used together for patients who have BRAF positive melanoma. So BRAF inhibitors can cause ATI, tubular injury, granulomatous interstitial nephritis, and also some cases of pseudo-AKI. I've also seen quite a few patients who are referred to us for electrolyte disorders on these new HER2 inhibitors. So adutrastuzumab and famtrastuzumab, just remember they can present with hypokalemia, which can be pretty severe. And there are reports of full-blown Fanconi syndrome as well. And then last but not the least is selinexor. This is used in myeloma when they've gone through, gosh, like 15 lines of therapy. And this is an EXPO1 inhibitor. And the thing as a nephrologist you should be aware of is these patients can develop hyponatremia, which can be pretty severe. And it's not quite clear what the mechanism of hyponatremia is from this agent, but nevertheless, it's not used very often. But when you see one, you should look at the drug list carefully to identify this association. So just to summarize, as I've showed you with a lot of these agents, true AKI is common, but problem is that pseudo AKI can also occur. And cystatin C, although we use it, has its own limitations in cancer patients, and we don't think it's ideal. But if you have both creatinine and cystatin C going in the same direction, it may reassure you that it is rather either pseudo AKI or AKI, depending what you see. And if it's going in opposite directions, of course, you think of pseudo AKI. Measurement of GFR, unfortunately, is good, but we don't have it available at most centers, which can create a big challenge for our patients. And pseudo-AKI, one of the clues I look at is the degree of rise in creatinine, because I don't expect the creatinine to be very high when it's pseudo-AKI. And then, of course, associated findings of hematuria, proteinuria, etc. I did talk about PARP inhibitors because they don't necessarily have a lot of AKI, true AKI reported with them, but they are very commonly associated with pseudo-AKI. And as I mentioned earlier, the CDK4/6 inhibitors and agents that target the MATE1 transporter in the kidney, such as ALK inhibitor, EGFR inhibitor, and RET and MET inhibitors that I didn't describe in detail, but it's probably worth mentioning that these MATE1 inhibitors are all used in lung cancer patients. And in my old institute at MSK, they looked at this data where a lot of patients were on MATE1 inhibitors for lung cancer and had this rise in creatinine-based AKI, and they had cystatin C and creatinine available in 15 of those 17 patients, and in 15 patients, the cystatin C did not correlate with the creatinine-based GFR. So just something to remember that pseudo-AKI is a very common adverse effect of a lot of these small molecule agents. And last but not the least, one slide on PERT therapy. So if you focus on PERT, I'll talk about the blue box first, which is Lutathera. So this is the older one, and most of you probably are aware of it. It's used for neuroendocrine tumors. It targets the somatostatin receptor. And based on the structure of Lutathera, it does get absorbed in the proximal tubule, so the kidney can get radiation-related injury. And in Lutathera, the co-infusion with cationic amino acids like lysine and arginine inhibits the absorption of radiopeptide from the proximal tubule. So if it's infused with the cationic amino acids, AKI is quite rare. But the problem with the cationic amino acids is they will cause transcellular shift of potassium, and these patients can have hyperkalemia. So those are the consults you may get in the inpatient setting. And generally speaking, if the kidney functions normal, the hyperkalemia resolves very quickly. You should monitor these patients for myelosuppression if they have underlying CKD. Now, Pluvicto is the newer PERT therapy that is approved for metastatic castration-resistant prostate cancer, and this targets the prostate-specific membrane antigen. What's important to note is you do not need co-infusion of amino acids with Pluvicto. AKI is very rare, but we've had some very long discussions in tumor board meetings about the risk of AKI if the patient has metastatic disease involving the kidneys. And we've had a lot of prostate cancer patients with mets to the kidney. And we don't know if in those cases there will be more nephrotoxicity because the assumption is that tumor expresses PSMA, and as you target those, there will be some collateral damage to the kidney. The use is not approved for patients in GFR less than 30. And if you are going to use it, you're going to have to monitor them for myelosuppression because that's one of the major adverse effects. And I'll add that there are some anecdotal reports of TMA with this agent, and this is not published, just based on discussion with other onco-nephrologists. So not sure if that is a true association, but something I wanted to add to the discussion in case some of you see it. Make sure that you mention it or publish it because it's something that we need to clarify. So now to summarize, as I said, targeted cancer therapies have changed the landscape for various cancers. These really provide the backbone for personalized medicine in cancer. But as I showed you, cross-reactivity with normal cells can cause systemic toxicities. And it's extremely important to recognize the kidney-related toxicities for quick diagnosis and quick management to preserve kidney function and resolve electrolyte disorders sooner rather than later. So with that, I will end the talk, and I hope I have a good 10 minutes for discussion and questions. Thank
We
you.
do. Yeah. Thank you for that wonderful overview. I don't know how you keep all these things straight in your head, BCR, ABL, CDK, the alphabet thing. And you seem to talk like an oncologist. So is it because you're doing a lot of onco-nephrology, or do you really work closely with the oncologist to understand
Yeah,
all
so
these things?
I think absolutely. So the reason you do this is you have to spend time with them. So at Sloan, I had the luxury of doing exclusive onco-nephrology for 4 years because being a cancer center, you only get patients who are cancer survivors or have active cancer. So I think that was the key here. And fortunately at Penn, because we are so large, a division, I have the luxury to say I'm only going to see onco-nephrology patients in my clinic. So inpatient setting, also we have an onco-nephrology inpatient team. Sometimes we get other patients on it, of course, based on the census. But so that's I think the key to develop expertise and to kind of speak their language, so to speak, you know.
Yeah, yeah, absolutely. Greg?
Thank you for that talk. That was great. I mean, I just wonder, maybe you mentioned this right from the start, but a lot of like when you look at especially FDA trials and phase 3 studies, the side effects are always tend to be overreported. And then a lot of these things that any case I've kind of come across when I, search it, it always seems to be a lot of case reports. And so I guess what I'm asking, is there any better like cohort data that shows true incidences of these things where you have a group of people that are just doing fine, and yet you do have your baselines of how many get AKI, how many get proteinuria? Because I mean, I have a feeling it tends to exaggerate these things when you look at, like I won a couple weeks ago on call, you look it up and you get 5 case reports. So you think it's like,
Yeah.
it's occurring in everybody or something. But do we know the true incidences of some of these things?
So I can tell you, so when we looked at, so the first thing is like, I'll take the common agents first. So like VESP inhibitors are that side effect profile. If you look, it says 20% to 90%. I mean, these are large, cohorts. These are not case reports. Like at Sloan, I looked at 13,000 patients that had received any form of VESP therapy from the day the first VESP was approved till 2023. And so there's a huge um, variability. So, for example, given the patient mix we see, the number of patients we have, our incidence of those cases may be slightly different than an institute that doesn't see that many cancer patients and then it gets blown out of proportion. But you're absolutely right. Like this is the challenge with these agents that they are not very common adverse effects, especially with some of these targeted therapies. Like VESPs, we know proteinuria hypertension is common. So that is, I think, a well-described, well-associated association. But even within that, there's so much variability is the point I'm making. So there is no way unless we create sort of a registry or a database where we can actually include every patient who's receiving this agent and then sort of monitor what is a true incidence. The problem is not just the true incidence. As I told you, we still struggle to define pseudo AKI from AKI. And that's half my challenge in nephrology clinic is which ones do I need to biopsy and which ones am I safe to monitor for a few more months? Because a lot of these patients have risk factors for kidney biopsy. Their platelets may be low. So I don't think I have a good answer. Short of a registry that is well run, I don't think we'll ever know what the true incidence is. I would say it's rare for severe adverse effects, which is why I was showing that FIRE's data that we don't get 50% people on these therapies into our clinic. We would not be able to do anything else in nephrology if that were the case. But the point I'm making is I think perhaps most are mild, but nevertheless, I don't think we know the true incidence. And these agents are newer, so it's more, I think we have to rely on case reports for the rarer side effects and then hopefully larger cohort studies. But except that there will be a lot of variability. And how do you define hypertension? How do you define proteinuria? That also creates the challenges in describing the true incidence. And nephrologists describe proteinuria based on the CTCAE adverse effects. So if you look, they describe grade 2 proteinuria as anything between 1 gram and 3.4 grams. I mean, go figure. Like, that does not correlate with anything we nephrologists are used to. So that's probably why there is also variability in larger cohorts.
Thanks.
Yes. Yeah, so a database would make a lot of sense. And the electrolytes, again, these are all reported. We rarely get these cases to us. I guess only the
Yeah.
very severe cases are referred to us. So are oncologists, in your experience, are they dealing with these things? Are they becoming sort of semi-nephrologists dealing with some of these toxicities on their own?
I completely agree with you. The cases of hypokalemia that I got from trastuzumab patients, the Enhertu patients, were after they had tried like IV potassium and oral potassium. So a lot of these patients are already on potassium replacement, and the oncologist starts them, and it's only when they're not able to fix it despite what they normally do, then they'll refer the patient to us. Even with hypertension at MSK, they were so comfortable with managing the hypertension from VESP therapy that I would only see those patients after 2 or 3 lines of therapy were already on board and patient was still not well controlled.
That's super interesting. There was a question in the chat about the toxicity of ocular VEGF. Can ocular
Yes, yeah.
VEGF inhibitors cause kidney
Yeah.
toxicity?
So absolutely, there are several again case reports. I think if I remember looking at it, there've been about 20 reported cases the last time I looked at it of systemic TMA, renal TMA caused by ocular VEGF inhibitors. So it's something that we keep in mind when we are taking history from these patients if they have proteinuria. So don't, yeah, and this can be easily missed if they're seeing a ophthalmologist that's not in your EMR and you can't see it. So it's something important to ask. However, it must be again extremely rare because so many patients get this therapy for macular degeneration. So I am not sure how common it is, or how I can't even say how what the incidence is because if there are only 20 reported cases, but the caveat is we don't know how many we are missing. So it's
Right.
always tricky, but yeah, there are reported cases of it that you should be aware of and do elicit that in your history when you see the patient.
Right. And you talked about various different ways of attenuating, like switching or lowering the dose. When we talk about toxicities of other drugs, right, we believe it's a class effect, right? If ACE inhibitors cause hyperkalemia, all of them, sorry, or they cause cough, all of them cause a cough. How do you explain the fact that, within the same class, some of them have, one versus the other side effect?
Yeah, and I think that one of the reasons I had the slide done the way I did is, and I listed all the receptors and the pathways was exactly that, because that is the question that bugged me from the very beginning. Like, oh yeah, this is a tyrosine kinase inhibitor, but when you start going into the actual molecule and then why do we need 7 in 1 category? And it's really because they are slightly different from each other. And some agents like CDK4/6 inhibitors, we did not feel comfortable starting that patient who was on palbociclib on ribociclib. That's something neither the oncologist nor I felt comfortable with because A, it was an interstitial nephritis kind of a reaction, and B, we didn't feel there was that much of a structural difference between the two drugs. So I think this is something each drug, each agent, this is a discussion with the oncology team that you'll have to ask. But there's some categories where you can try to do this, but some I wouldn't, depending on the mechanism of action of those drugs.
Right. But that will require some understanding of, are these two truly different or not,
Exactly.
and talking to them. It's almost 9. If you can have time for one last question. On
Absolutely.
the immune checkpoint inhibitors and AIN, I mean, we know they cause AIN, but normally when we think of AIN, it is, a drug gets started and patients get AIN. But in sometimes we see this later also. The timing doesn't seem
Yes,
to help. Is that
yes.
the right way? How should we think about that?
Yeah, so that's a very good question. So immune checkpoint inhibitors, if you look at the largest retrospect, and this is all retrospective, unfortunately, because only 1 to 3% people develop AKI and AIN. So in that cohort, the median time to onset of AKI was after 4 months or 4 doses of immune checkpoint inhibitors. But if you look at the pyramid, it could occur as early as a month and sometimes as late as a few months after stopping the therapy. So, immune checkpoint inhibitors are such that you should not exclude the possibility, even if the patient stopped the drug a month or 2 months ago, because we have seen up to 4 months later immune checkpoint inhibitor related AIN. And this is the point the oncologist makes to the patient that just because we are stopping the drug, that pathway of immunotherapy that you have started with the immune checkpoint inhibitors doesn't stop when you stop the drug. So this is actually reassuring to the patients when we say we're holding therapy for a few months, but we don't expect the effect on the cancer to just disappear within a few days. So let's give it some time. The timing of onset, as I said, median is 4 doses, which is typically given every 3 weeks, about 4 months. But there is variability. The other thing you should always bear in mind is ask the patient or look at the record if they've had prior immune checkpoint inhibitor exposure, because I have seen AIN happen much sooner if they've had previous exposure and didn't have AIN then, but that counts towards their exposure. And the other thing that's important to note is that with immune checkpoint inhibitors, you can re-challenge them if they have AIN. And then the third point is that the clue to AIN is if they have other immune-related adverse events, namely they get colitis or like skin manifestations. So your chances of this being AIN due to immune checkpoint inhibitor is higher if you have other coexisting immune-related adverse events. So if you see AKI in that setting, you should immediately think more of AIN than other causes of acute kidney injury in those patients.
Awesome, thank you. It's just clear how much having seeing these patients all the time makes such a big difference. And we are at time, so I'll stop now. But in case people uh, have any questions, I know where to find you. But
Okay.
is it okay if
They can
we
email me.
if we have any
Yeah,
difficult situations that we contact you?
absolutely. You can share my email with them.
Fantastic. Thanks again, Aisha.
You're so welcome, and thank you for having me today.